or secondary endocrine resistant patient. So that proportion was 22% in Paloma 2. It was only 1% in Mona Lisa 2, and it was 0. So these patients were excluded in Monarch 3. Why? So you will come to know that endocrine resistant is a relatively worse group compared to endocrine sensitive. So the other trials of Mona Lisa and Monarch included only the good patients, which usually happens in all the clinical trials. They pick up the best patients and show the greatest results. Unfortunately, Paloma trial didn't do that, or by mistake, they had 22% of the patients who were endocrine resistant compared to 1% or none in other trials. So the endocrine sensitive subgroup is really the one which is driving the survival benefit in most of the study groups. So what do you think about the Paloma 2 subgroups results for patients with disease-free interval more than 12 months? Sorry for this. Just a minute. I think there was a graph which is not available, but so there was another Kaplan-Meier curve of disease for patients with disease-free interval more than 12 months, where the OS benefit is even more. I can say somewhere around 64 months versus 44 months. So palbociclib use in patients who are endocrine sensitive, there was a post hoc analysis, and there was a delta of 20 months, and the hazard ratio was almost 0.72 or 0.73 for overall survival, which is quite comparable to other CDK4/6 inhibitors which we see. So based on this, do you think that Paloma 2 subgroup results for patients with DFI more than 12 months should be taken into consideration, and the patients who had DFI less than 12 months were the ones who pulled down the results of the overall intention to treat population, and hence we didn't got a OS benefit with palbociclib? Doctor, we'll start with Dr. Ashish Agarwal. What is your take on this after discussing the last few slides? Dr. Ashish Agarwal?
Yeah, I think in Paloma trial, they also included a patient with DFI less than 12 months of group. And we know that DFI is less than 12 months is a poor prognosis and worst group. So obviously, we can consider adding of hormone therapy plus CDK4 inhibitor in this group of patients.
Fine. Dr. Avinash Talele?
Yes, Dr. Chintan.
Yes.
So yeah, I agree to the fact that because if the DFI is less than 12, they are endocrine resistance to begin with, and naturally they will fare poorer as compared to the endocrine sensitive subgroup. So the arm itself is they have a good natural history. So that is why I think the difference is there.
Fine. So I think most of us agree with this, right? That there is some discrepancy in the patient subgroup in the trials, and because of that, somehow palbociclib lagged behind the other two drugs and wasn't able to show the overall survival in the intention to treat population. Right? Anyone would have any difference of opinion in this? Okay. So this is again what we discussed, that do you agree that 22% of the endocrine resistant? I think, am I missing, I think one of my panelists, one more of my panelists. Is he there? Prashant, can you just mention
the
name?
Dr. Murtuza is there.
Murtuza, yeah, sorry, Murtuza.
Dr. Shivam sir and Dr. Murtuza sir.
Dr. Shivam Murtuza and Dr. Yeah.
Ashish
Dr.
sir and Vinash sir.
Just a minute, sorry, I think. Yeah, Dr. Shivam, what's your take on this?
No, I think you've driven the point very well that different clinical trials have taken different subpopulations, and this is what we've seen with the abemaciclib adjuvant trial. So I think the resistant population has pulled the overall survival graph down in the Paloma 2, and if we take the patients with endocrine sensitivity, I think the OS benefit comes back again. So we have to take the data with a pinch of salt and analyze different populations completely differently in our clinical practice.
Perfect, perfect. Well attended. So Dr. Murtuza, what is the percentage of patient in your clinic clinical practice that you find who are having DFI less than 12 months, that is who come with endocrine resistance and who are endocrine sensitive at the time of relapse?
I think in my practice, almost 30% patients are endocrine resistant, and more than I can say 60 to 70% cases are they are endocrine sensitive. Generally, this disease, when the patient presented to us, sometime after the completion of the therapy 2 or 3 years, then they relapse, because this is the nature of the hormone positive disease. They relapse on a longer time period. So this is my experience. I think might be different for somebody else or quite similar.
Yes. What's there at your clinic, your practice, Dr. Ashish?
In my practice, around 20% patient they are endocrine resistant,
Okay.
and
Rest 80 are sensitive. Dr. Avinash?
Yeah.
Same, or you have?
Yeah, Dr. Chintan. So my practice, around 30% of them are endocrine resistant. 70% are sensitive.
Dr. Shivam?
Yeah, I also agree about 20%.
Nearly one third of our patients. So
nearly one
most of
third,
us,
yeah.
Yeah, so 1 out of 3 patients are resistant and maybe 2 patients are sensitive. That's the rough scenario. 1 out of 3 or maybe 1 out of 4, right? 25 to 33%, somewhere we can say 2 out of 3 patients. Fine. So what is the difference? Do you find any difference in these scenarios while treating them, Dr. Shivam?
So patients who are endocrine resistant, they generally do not respond better and they have a worse outcome. This is what I've seen in my practice. And majority of these patients have visceral metastasis. So this is what I've seen. They do not do well with whatever treatment we give them.
Correct. So would you still stick to this option of CDK4/6 plus AI, or you have some other option in mind or some other combinations in mind?
So I do prefer them. I want to do an ESR1 mutation testing in such patients and look at the receptor for estrogen. Then I do offer them AI plus letrozole. This is the most accepted option as of now.
Right. But you just you are ready and you explain the relatives and the patient as well that maybe we are going to relapse sooner compared to somebody who is endocrine sensitive.
So I weigh down their expectations from the treatment, so keep them on a realistic note.
Perfect. And anybody would like to have a different opinion, or most of us agree on this?
In my opinion, it's all depend on what's the condition of patient, what is the site of metastasis, visceral metastasis, is there any visceral metastasis there or not. And I also do PI3 KCA testing on this patient.
Correct. So ESR1 is one and PI3CA is also one. So nowadays, most of the time, again, I think most of us are sending PIK3 on day 1 on the initial biopsy blocks. Right. So anybody is doing a different thing. Anybody is testing it later at the time of relapse by a rebiopsy, or most of us are sending on day 1 on the first biopsy sample.
Mostly, I'm sending after progression in my practice.
Okay, Dr. Avinash, you also send it after progression or on day 1?
I send it after progression.
Okay, Shivam, Dr. Shivam.
No, I am doing it on at the time of presentation because it's a stable mutation, and you don't really need to rebiopsy.
Right. So, Dr. Murtuza, your take on this?
We can send on archival tissue also. So I also prefer to send on upfront stable mutation.
So going off this track, what is the percentage of PIK3 positive you all have found? Because the data say it is 30 to 40%, correct? But I think unfortunately I haven't found such a high rate of PIK3 positivity in my practice. Anybody has seen that your 3 out of 4 patients coming PIK3 positive?
No, very rare.
I have sent in 10. I have sent in 10 patients. I found on 3 positive, and they are still doing good on palbo or ribo. So
you found positive in 1.
3 patients out of 10.
3 patients, so 30%. Yeah, fine.
So unfortunately, I have been finding it less. So
correct. Same
around
here.
10 to 15%.
I am 10. I agree at 10 to 20%. Not more than 20%.
Correct. Even my belief was that instead of the 40% what has been said in the trials, I mean, I am also finding hardly 10 to 20% positivity of PIK3CA. Maybe it's the different disease or a different biology and based on the genetic factors or the demographic factor, I am not sure. And secondly, whether I'm also doing it upfront on day one because thinking that it's a stable mutation because it's going to be present since the beginning. That's what understanding we have developed. But should we rebiopsy and recheck? That's one point I'm not sure of because of the low yield of PIK3CA compared to the data which we read. So I think that there are no answers to that.
Most of the paraffin blocks which are there, the quality for diagnosis wise they suffice. Okay.
Correct.
But the DNA extraction and the molecular signatures, so we really do struggle for them. And the ER positive disease, even the bone yield is not, the sampling from the bone is not that great.
Correct. So that's a good point. I think
prefer to get
so bone lesions should be avoided. That's very true. Even the ER positivity sometimes is we don't get the ER positivity in the lesions biopsied from the bone. So that's a very important point you have derived. So I think these are both the points we have discussed in quite detail, and we have gone a little beyond it with the big three also. So I think all of us agree that 22% of the endocrine resistant population have impacted the overall survival in PALOMA-2 for the intention to treat population. I think yes, everybody get the same answer. This we have already discussed. So the effect of palbociclib in endocrine resistant patient, somehow PFS is not affected based on the data we have, but OS is yes definitely affected, especially by the missing survival data, as you can see in the forest plots which are presented here. So in what is the acceptable loss to follow-up or missing survival data in clinical trials? So typically investigating drugs or other therapies in RCTs, it has been suggested that the loss to follow-up more than 20% pose serious threats to validity of the data, and even more than 10% may pose biases in the statistical analysis. In PALOMA-2, there was a disproportionate loss to follow-up or missing survival data between the palbociclib study arm and the control arm, 13% versus 21%. So each had more than 10 or more than 20% loss, and also the discrepancy was little high, that is 8%. So what is this impact of, do everybody take this point? So honestly, for me, this was a new point. I was honestly not aware of this missing survival data point before going through the slides. So anybody has any idea on this, would like to share? Any one of you, any of the panelists, Shivam, Murtada, Ashish, Avinash, any one of you?
So I always used to think that it's the investigator's prerogative to give us data in a form which is acceptable to them. So now I am listening that the data has not been followed up because they were lost to follow up. I agree with you. This is a big point, but I never knew that the investigators would publish this without a caveat that there was a lot of missing data and report a negative trial.
Yeah, so this was interesting because I think these are all post hoc analysis just to find out what went wrong with palbociclib in showing the OS data. So in doing so, I think they have come across these points and they have highlighted that this may be one of the reasons that the drug didn't do well in the intention to treat population. And they again consulted the statisticians and figured out that what is wrong in this, and they pulled out this point. But I'm not sure how well and any statistician is there right now, and anyone from the Pfizer medical team would like to comment and highlight on this issue of missing survival data. Anybody from the Pfizer medical team? Okay, I think there's no.
No medical team is there in
fine.
Today's meeting. Okay, so we'll get back to you on this.
Okay, no issue. Fine. So again, this is very interesting. I found that clinical trial endpoint for tumor with post-progression survival of more than 12 months. So National Cancer Institute Breast Cancer Steering Committee Working Group reported meaningful and appropriate endpoints for clinical trials in metastatic breast cancer. If you see triple negative breast cancer, first line, second line, third line or more, primary endpoint is always OS, OS and OS. because of the short survival period and the short progressions. In hormone negative, HER2 negative, it is both PFS and OS, irrespective of the line. In triple positive, also it is same, PFS and OS. But if you see hormone positive and HER2 negative, because they were very long survival, they have very long post-progression survivals also, it is only PFS, primary endpoint of in first line and second line, only PFS is the ideal point where patients are going to live long, and even the subsequent therapies are going to be longer. This is the conclusion they have derived at based on the post-progression survivals. So considering the Paloma-2 data readouts and the limitation, do you consider OS as a class effect for all the CDK4/6 inhibitors? Yes or no? And if no, then why? Let's start with Dr. Avinash.
I missed out on your question, Chintan. Can you just please repeat?
Yeah. So do you think that OS benefit is a class effect of all CDK4/6 inhibitors?
Class effect of all CDK4/6. Yes, of course, I think that.
Yes. Okay. So you believe it's a class effect. OS benefit will be there with all the CDK4/6 inhibitors.
Yes, yes.
Dr. Ashish?
I think looking at all the trials, the main advantage is the PFS advantage, and the OS is variable on all these trials. So though we consider PFS is a surrogate market for overall survival, but still I think now data is coming, so OS is a class effect for CDK4/6 inhibitors in my view.
Okay, fine. So you accepted that OS is the class. You also agree. Murtuza and Shivam, you also agree, or you have a different opinion?
No, we agree with the other panelists.
Yeah. And Prashant, yeah, I think there is one more panelist. I think fifth panelist is there. Prashant.
Dr. Murtaza
Yes, sir. Dr. Shivam is there.
Shivam, Murtaza, Ashish, and Avinash. These are the four panelists we have.
Absolutely.
Sorry for this, but
yeah,
I'm not missing out on anyone, right?
Yeah, right.
Fine. Because I had one more name, so that's why I was confirming. Sure. Thank you. So we all believe that despite the Paloma trial was not able to show OS benefit in the intention to treat population, OS is a class effect of all CDK4/6. Maybe the trial design and the patient subgroups were the one which led to this. And we know the side effect, again, they are also different for each of these three. And palbociclib, we all know neutropenia is the bothersome side effect, while diarrhea with abemaciclib and hepatitis and QTc prolongation of ribociclib, these are relatively specific to each of this drug, CDK4/6 inhibitors. So Paloma-2 met its primary endpoint of improving PFS and other secondary endpoints. Overall response rate of 55% in the palbociclib arm versus 44% in the placebo arm. And the safety profile was consistent with the older data, and the quality of life was maintained. The OS was numerically longer, but the results were not statistically significant. Median survival of over 50 months in this population still represents a significant improvement in the natural history of hormone-positive breast cancer, especially in the subgroup of patients who have disease-free interval of more than 12 months. The median OS was 66 versus 46 months, a delta of 20 months. And 10% of the patients do continue this palbociclib even after 7.5 years of follow-up. Interpretation of OS in the Paloma-2 is limited by the large and disproportionate percentage of patients with missing survival data between the treatment arms, and secondly by the 22% of patients having endocrine resistance. These are the two limiting factors which may have led to the non-significant OS. So in the recent ESMO Breast 2022, P-Reality X was presented. This was a retrospective observation analysis of electronic health records of patient data from the Flatiron Health Analytic Database. So the real-world study are now increasingly being used to understand the safety and effectiveness of new drug regimes in clinical practice, and to examine the real-world effectiveness of this palbociclib AI versus AI alone in first line. This analysis was done. And if you see the size of the data, it's huge. Over 3 million patient records were there, 75% from community practice and 25% from academic centers. And there are more than 280 community cancer centers and 8 major academic centers of US in this health record system. So the objective was to evaluate the effectiveness of palbociclib plus AI compared to AI alone in the hormone positive HER2 negative MBC setting in the real world patients in US It was a retrospective cohort analysis of electronic health records. And to minimize the errors which arise due to lack of randomization, they introduced two statistical things. One is SIPTW, that is stabilized inverse probability of treatment weightage and propensity score matching. So what is this? We'll just see. Whenever there is real world study analysis, they lack randomization, and because of them, they are prone to be influenced by various different characteristics and multiple different biases of confounding or missing data, misclassification, or selection bias. In order to minimize this, this statistical techniques are being designed for the real world studies. Two of them were used in this. One is inverse probability treatment weightage and propensity score matching. Aim of the IPTW is to adjust for differences in characteristics of study subjects by adjusting weighting assigned to variables. While the aim of propensity score matching, it is to match patients across various treatment groups according to the demographic and clinical characteristics. The goal of IPTW is to create a pseudo population where all patients resemble a reference population. While the goal of PSM is to compare patients with same propensity score, but who receive different treatments, just like randomization, which happens in RCT. So advantages of IPTW are to keep all eligible subjects, also to have more than 2 comparisons, while PSM gives the advantage of treatment effects can be directly compared between the matched patient groups. So propensity score matching, this is the diagrammatic reference. There are multiple different patients, and you sort out a study group who have similar parameters, clinical and demographic parameters, where you can compare. While patients who are unable to match are excluded. Your so size of the total or sample size goes down in the PSM. While in IPTW, so there is an original population with variable characters of different sizes. You weigh all patients according to the inverse of probability of treatment that is calculated from PS. So there is pure statistics. Honestly, don't ask me the details of this. So there is a pseudo population they create by this. And what difference I found is this preserves the sample size of the original data. So there is no exclusion in this, and it can have more than 2 or 3 comparisons. So based on this, they had an unadjusted total cohort, another cohort adjusted according to IPTW, and cohort according to PSM, where they compared, made it a comparative data, so that that is close to the analysis is to minimize the biases and make it as close as possible to the randomized control trial, which are the gold standard of any comparison. So the baseline characteristics were matched in, you can see in the tabular form based on this, and they published the overall survival data before and after this IPTW and PSM. So in all, for unadjusted as well as for stabilized inverse probability matching and propensity score matching, there was significant benefit of palbociclib over AI alone. So the hazard ratios were quite different: 0.67 in the unmatched, 0.76 in the IPTW analysis, and 0.72 in the PSM matching. So more in a single line, you can say there was median OS benefit while you add palbociclib to AI based on the real world data analysis. Also, the PFS was significantly better in all groups, that is unadjusted analysis, there was IPTW analysis and PSM analysis. So PFS was also better. So what is the strength of this P-reality X is the large sample size drawn from an extensive database of more than 3 million patient records of more than 280 community cancer centers and 7 major academic cancer centers. It tried to adjust as close to an RCT as possible by using this IPTW and the PSM strategies. The follow-up time sufficient to obtain median real-world PFS and OS estimates for both treatment arms, and the use of the statistical techniques to order to minimize bias arising due to lack of randomization. But there are significant limitations also. This method cannot determine causal relationship. It just tells us about an association. It's not a causal relationship. Disease progression are based on treating physicians' clinical assessment or interpretation of the scans or pathological results rather than standard criteria of RECIST. Furthermore, the assessment scans were not standardized with respect to the timing nor the requirements. Unlike it happens in RCTs that you do a scan at the fixed interval of time and you do a specific blood report for the specific to look for the specific progression or stabilization or scan. Although while you can say IPTW and PSM were used to balance the characteristics, unobserved variables cannot be fully addressed through this method. Still, you may miss out some parameters which are not comparable between the groups. Also, some subgroups analyzed may not have sufficient power due to the smaller sample size. So, these findings presented here may not be generalizable to patient population. Also, this analysis did not collected safety data. But still, based on this, we have a rough analysis saying that in real world, this drug does work well, and it can be the standard of care, which is already there. Again, publications where they have accepted even based on the real world data. So real world data is like a phase 4 study, like a post-marketing surveillance, just to see that the similar efficacy data is obtained, which was seen in the clinical trials. Again, this is really useful for us because many a times we see patients, as Dr. Murtaza also discussed, there were visceral mets, and rarely we do have a borderline patients who are not exactly in visceral crisis, but have a significant visceral disease. But they are not, the end organ damage is not there, but it's likely to happen very soon. And even in such patients, rarely, because the patient is frail, patient is old, we could not deliver chemotherapy. We had tried these drugs, and the CDK4/6 inhibitors have worked wonderfully well. So this real world data is like the practical situations many a times which we face in our routine clinical scenarios, and it does give us some more strength of evidence in addition to the RCTs which we already have. So considering the wealth of the data on CDK4/6 inhibitors across RCTs and real world evidence, do you think that there would be any change in treatment practice among CDK4/6 inhibitors? If yes, then all patient or restricted to certain patient. I think there is a wrong question. I think nobody would say that anybody would like to change the decision and would not use CDK4/6 inhibitor. I think anybody would like to add anything on this, I think, we should skip this question, because in today's era, I don't feel this is a relevant question of whether to add CDK4/6 inhibitor or not. So, can anyone share the attributes of palbociclib, the efficacy, the safety, and monitoring from their clinical experience? Dr. Shivam, you would like to highlight anything particularly? I would say,
I think it's a very safe drug in my clinical practice. Patients who have extensive bony metastasis, they only require CBC monitoring. Otherwise, the drug is very well tolerated. I do check CBC for the first 3 cycles, first week and end of the cycle, in the first cycle, and then for monthly for the next 2 cycles. And once it's pretty stable, I do continue on the same. Apart from that, I reduce the dose in patients who have severe neutropenia to 100 milligrams. So this is my experience. Otherwise, the drug is pretty safe.
Right, Dr. Murtaza, your take?
Same. But I would like to add one thing. We have seen many patients. They got the neutropenia, but not the febrile neutropenia there. So incidence of febrile neutropenia is pretty low. So we have seen the neutropenia in some patients, but quite tolerable, very well safe, and we have more experience now. Since 2016, we have experience, so pretty much tolerated by our patients.
Right. Dr. Ashish Agarwal?
I agree with both panelists. Palbociclib is a very well tolerated drug, seen very low grade of neutropenia, not febrile neutropenia. I do CBC after in first cycle after 7 days. If CBC normal, then before each cycle.
Right. Perfect. I think Avinash, would you have any difference of opinion? Would you, or you also feel the same?
Yeah, I agree.
Okay, fine. So we also have a good amount of Indian experience with palbociclib. This is the real world data published by Dr. Chaturabhuj Agarwal, Chandra Doval, Amit Agarwal, and team. And we almost have comparable results of PFS of 20 months in the first line and almost 12 months in the second line, response rate of 80%. Yeah, so again, this is quite striking as compared to the original study, Paloma 2, which had an overall response rate of 55%. So what is your response rate? Because we all see tremendous, very good results with palbociclib. So overall response rate is a combination of CR and PR. So we'll start the reverse way. Dr. Avinash, so what is your response? Roughly, you can say 50, 60%, or is it too high, like 70, 80%? Dr. Vinash is there?
Yes,
Okay,
yes, Dr. Chintan, I'm there. I was muted myself.
Yeah. Sorry.
Yeah. So in the second line, my median PFS in the hormone sensitive population is around 15 to 16 months. Yeah.
No, I'm saying response rate. Response rate.
In which line? First line, second line?
First line. First line.
Almost everybody has responded. So I have never calculated the response rate. It is more than
Right.
80%. I
Correct.
get
Dr.
to come
Ashish?
across any patient who has not responded, hormone positive patient who has not responded.
So I agree with Dr. Vinash. Is 70 to 80%. I think.
Right. Murtaza?
Similar, sir. We can say more than 80 because as Dr. Avinash said, we haven't seen any patient and no one of the patient has not responded. Either might be
Correct.
some stable disease after 4 but we know hormonal takes some longer time
Correct.
to respond. So might be, but almost all have responded.
Right. Dr. Shivam also, right? You would also agree with this.
Yeah, 100%.
So I think I am. This is again. So the response rate is say 90% or maybe more. Most of us we have never seen a patient not responding to CDK4/6 inhibitor. So I think 80-90% is somewhere we all see. So it's again a very good response rate which we all have seen, and it was reported by this trial. Again, there is another study in India from south of India by Dr. Amit Rauthan and Dr. Poonam Patil and the team. Almost comparable data, comparable side effects, similar data from Chennai, PFS of 18 months, OS not reached 1 year, PFS 73%. Similar data from Jaipur. So most of us have encountered similar things, and these are the reports which are almost replicating the international data. This is the slide I would like to highlight. The take-home message by the panel, practical consensus recommendation regarding the use of hormone therapy in MBC by Dr. Senthil Rajappa, Dr. Jyoti Bajpai ma'am, Dr. Mehboob Pasade and the team, all eminent doctors of our country. And these are the take-home message that in patient with MBC, available evidence does not support local treatment. We all know the decision should be individualized based on the patient, tumor cases, site and number of metastases, and response to systemic therapy. Endocrine therapy rather than hormone is preferred in hormone positive MBC unless or except in visceral crisis. Combinations of AI and palbociclib should be the preferred first-line hormone therapy for hormone positive MBC. Premenopausal women need to undergo ovarian ablation before starting this treatment. And if addition of palbociclib is not feasible, AI should be offered. In patient with bone-only disease, you can also add fulvestrant with AI. At present, ESR1, this is again an old slide, that ESR1 testing is not recommended, and PIK3 they have not mentioned. But with the available of alpelisib, we all do check for PIK3, and ESR1 is soon going to be available. So we will be checking for that as well. So this is the report from the ASCO meeting of 102 patients treated with palbociclib in hormone positive advanced breast cancer. So this is data captured from 2017 to 2022. So this is something, I mean, I don't believe that objective response rate is only 17%. So maybe this would have included patients who are on second line, third line, fourth line, maybe because it is too low to believe 17% of response. Maybe this is the patients who have taken it as a later line of treatment and not initially the first or second line. So in summary, all the CDK4/6 pivotal trials were designed to demonstrate a benefit in PFS. PFS is accepted primary endpoint in metastatic breast cancer by regulatory authorities around the world. Increasing evidence is available for RCTs demonstrating longer OS with CDK4/6 inhibitor plus endocrine therapy. However, the difference is OS was not statistically significant for palbociclib in the intention to treat population. Real world evidence of OS benefit for patient in this group in first line can help inform treatment decision in clinical practice. And these are the few important points by Dr. Richard Finn in ASCO 2022 OS update about Palomar-2, that it met its primary endpoint in all the groups. There was disproportionate loss to follow-up or missing survival data impacting the OS in the intention to treat population. Also, the DFI less than 12 months patient were 22% in the trial, pulling down the OS benefit. And multiple other factors may have impacted OS results with longer post-program survival in first-line therapy who go on to receive multiple therapies. Also, the power of the study and the randomization. MONALEESA 2 had a power of 90%, for OS, while Palomar 2 had 80% because of the 2:1 randomization in Palomar 2 versus 1:1 in Monaliza 2. So there are the salient features is highlighted, and we should not see that the gist of this. What I understood is we should not see that palbociclib didn't have OS, the other two drugs had OS, so it's an inferior drug. That should not be the message. I think Dr. Richard Finn wants to convey this, and I think I believe in this. We should take it more. All this are working in the same manner, with minor differences in the type of CDK2 and 9 they inhibit. So thank you everyone. Thank you Pfizer and my esteemed panelists for this wonderful interaction. Open to any question or discussion. Over to you, Prashant.
Yeah, so
Thank you so much.
Very much so much. Thank you very much, sir, for taking us through and in insights of palbociclib and various aspects of the study. Ruqayya, can you see any questions in the chat box? So there was a different link for attendees to join this meeting, and we have got this message that more than 30 attendees across West Zone have joined the meeting. So Ruqayya, is there any questions in the chat box?
Yes, sir.
Yeah, please check.
Yes, sir. Checking. No, sir. There are no questions for now.
Okay. So on the behalf of Pfizer, I like to thank you, all the esteemed panelists. So before concluding the session, just wanted to take a last take-home message from each one of you. So starting from the Chintan Shah sir to Murtaza sir, please.
So take-home messages: CDK4/6 inhibitors are first-line treatment option in hormone-positive, HER2-negative MBC without visceral crisis. So that is one. Secondly, all three agents available, CDK4/6 inhibitors available in the country, are equally good. So when you have agents which are equally good in terms of efficacy, you choose them based on toxicity profile. Somebody, say, a patient of IBS or inflammatory bowel syndrome or inflammatory in such patients. Suppose the cardiac or use
Murtaza sir, your take on this?
Yes, the standard of care for any metastatic breast cancer in first line as well as in second line is CDK4/6. Totally agree with Dr. Chintan Shah sir that if we have a similar efficacious agent with us, choose wisely according to their toxicity profile and patient profile also, and patient's comfort also. So depending on the patient's comorbidities as well as their financial burden, we have to choose our agent, and we should not hesitate using the best for offering the best available agent to our patient.
I'm sorry, there was some connection issue. Yeah.
Shivam sir, your take on?
So I think I agree with everyone here. I think in hormone positive space, the first option is CDK4/6 inhibitors. All of them are alike in a metastatic setting. Palbociclib was the first one. We have the maximum experience with this, and we may stick to this drug.
Yeah, right, sir. Avinash sir, your take on this?
Yeah. So I agree with what Dr. Shivam and Dr. Murtaza and Dr. Chintan said. It's a standard of care. There's no second thoughts on that.
And last but not the least, Ashish sir.
I think I agree with all the panelists. Now we are in the good era that we are giving palbase or palbociclib to each and every patient now, because it's become affordable. So many Indian patients which are not affordable initially for palbase, now they are affordable for this medication. So now we are reaching to wider population for this medication. So I think it's one of the good thing now. And palbociclib plus hormone therapy is one of the good option for hormone sensitive in first line setting, even second line setting.
Yeah, right. Thank you all of you for sharing your experience and experience with this palbociclib. And we would like to give thank you to each one of you for sparing your time and from your busy schedule. Especially thank you, sir, Chintan Shah sir, for taking us through the various aspects of the Paloma and the palbociclib. Just last but not the least, I just wanted to share the recently patient assistance program for this. Earlier, we used to have a standard pack like 9+ lifetime, but currently with the introduction of various generic drugs in palbociclib, we have revised our pack, and that is now patient has to purchase only 1 box and patient is eligible to get 3 boxes free, consecutive 3 boxes free. So if you see the average cost for the month for the patient would be 18,500 rupees per month. So that is the current pack available with us with original Palbase. So if there are no questions and no, so we would like to conclude this meeting. So thank you very much, sir, all the esteemed panelists, and thank you. Have a wonderful time ahead. Good night.
Thank you, everyone. Bye. Thank you, Prashant.
Thank you, everyone.
It was a pleasure being with you all. Bye.
Thank you very much, sir.
Same here, Avinash. Thank you, everyone. Bye.
Thank you, sir.